Today in the series of Docplexus KOL interviews, we have Dr. Unnikrishnan with us, who was formerly a professor at Endocrinology Institute, Kochi, and now is the CEO at Children Diabetes Institute, Pune. So thank you so much for giving us your time. Sir, why did you choose medicine as your profession and why endocrinology in particular?
I think it's an important question, and to be frank, my father and my mother wanted me to be a doctor. So because of that desire which I could see in them that their son should be a doctor, I consciously decided to choose the medical profession, and I think their suggestion has not been in vain because I've enjoyed every bit of it. Now, endocrinology in particular, that's also a very fascinating question, because if you look at endocrinology, it has got the entire spectrum of medicine in it. At the same time, it has got a science to it. Now, I am a person who likes to read, to think, and to philosophize about medicine. And therefore, a subject like endocrinology, where you can think about the hormones and their changes and their feedback loops, has a mix of very common diseases like, for example, diabetes and thyroid diseases, as well as the very rare diseases like the pituitary diseases. So, the variety of diseases that one gets to treat as an endocrinologist made it a very fascinating subject for me.
That is great, sir. Sir, you are the CEO at one of the best diabetes institute in Pune, the Children Diabetes Institute. What challenges did you face being a CEO over here, and what motivated you to overcome them?
I think the Children Diabetes Institute has been a fantastic learning experience for me as a chief executive officer here and as an endocrinologist, because I am looking after the patient care, research, education, as well as a philanthropic rural outreach program. So we are a not-for-profit institute, and our broad aim is to make an impact on diabetes in general, and probably something which will have an impact on diabetes worldwide as well. It has been excellent to learn. At the same time, it has been thrilling in its own way, because earlier I was a professor of endocrinology and I had DM endocrine students, and I had a very defined way of working. Whereas now I look after so many aspects of diabetes that my vision has broadened, and I'm having fun because there is no defined way to take an institution, to work in an institution and take that institution to the next level. So I am actually enjoying myself immensely in this task of helping build a good institute that can change the lives of millions of people with diabetes, and that's a very noble thought, and that inspires me to work at this institute.
Sir, as you said that you were formerly a professor of endocrinology and you have a teaching experience. Every student who has completed his MBBS would like to have a mentor like you. So, do you have any programs where doctors can learn from you?
Yes, at our institution, we have regular programs which are training programs on diabetes. Importantly, we have a training program called Advanced Course in Diabetes and Cardiovascular Diseases, which is a program created, the curriculum has been created by the doctors, the cardiologists, the diabetologists and the nutritionists of our own institute, and that program is conducted across the country by the Public Health Foundation of India. In addition to that, we are also a center. So if you visit the Chalaram Diabetes Institute or the Chalaram Diabetes Hospital's website, the doctors can actually go on, download the application form and participate in this certificate course, which is a series of classes we hold for doctors on every Sunday. It's held over a period of 6 months, and there is a certification. And of course, it is more like a continuing medical education program, but it focuses on diabetes and the heart. And as you know, cardiovascular disease is one of the most important comorbidities that can occur in diabetes.
Sir, as you said about continuous medical education programs. So, sir, are there any upcoming CMEs at the institute so that doctors on Docplexus can actually come and enroll themselves and get the best out of it?
Yes, so we have two such programs. One is called a CCMTD, or the Certificate Course in Management of Thyroid Disease, and that is a CME certificate course. There are 4 modules spread across 4 months on a Sunday, and again, candidates who wish to register for this can go onto our website and actually register for this course, which we are conducting in association with the Public Health Foundation of India. And this course also has been developed by our own internal staff, as well as validated by a national panel of thyroid experts.
Okay.
So this is an interesting course. In addition to that, we are accredited, the Chilaram Diabetes Hospital is accredited by the Maharashtra Medical Council for credit points for CME programs in diabetes, and we conduct a CME every 3 or 4 months. The next one is, I think, coming on August 23rd.
That is very
And viewers can visit our website or our Facebook page and get more information and register for these events in advance. And we'll be very pleased, because one of our important aims to make while making an impact on diabetes is education, and education of healthcare providers, doctors, paramedics, as well as patient education. I think this is a very, very vital pillar of our institute, and we are very interested that doctors come and get the best training they can, best knowledge they can in management of diabetes and related diseases like thyroid disease and other diseases. Yes.
Sir, if we talk about technology and patient awareness, both of the two criterias have made tremendous changes in past decade. So like if we talk about patient awareness, 2 years back, 1 out of 10 patients were suffering from hypothyroidism. And 1/3 of the population was not even aware that they are suffering from the symptoms of hypothyroidism. Has the ratio changed, or it is still the same in India?
I think if you look at the data, which was, I think our paper, which was published 2 years back in the Indian Journal of Endocrinology and Metabolism, which was the 8-city study on the prevalence of hypothyroidism in India, and we had data suggesting that at least 1 in 10 adults in India had a thyroid disease, particularly hypothyroidism. I think there is better awareness of thyroid disease today, because patients are increasingly aware and doctors are aware. But whether that awareness has gone from urban to interiors of India, has it gone to rural India, are people in rural India aware of thyroid disease, about hypothyroidism? I think that is a challenge, and we as doctors must continue to look beyond our profession and try to take awareness about diabetes and thyroid disease to the people, because we as doctors usually treat patients with medicines and do tests, but I think there is a responsibility that we feel towards the community, and I think it's very important that we take this forward to the community. With regard to diabetes, we have a magazine called Diabetes Health, and that is, you can check it on the website, you can Google or check it on the internet, Diabetes Health, and that is a magazine we bring out for patients every 2 months. And I think efforts like this will help raise the awareness of diabetes, thyroid, as well as other endocrine diseases in the country.
So the second aspect I was talking about, the change in technology. Sir, has there been any research on technology, or technology has helped to save more lives recently?
I think the power of technology is immense. Right from the use of technology to detect blood glucose levels. For example, if you just take that bit of technology, it has changed immensely. Earlier we were telling patients to use a glucometer, and then we were checking their blood sugar. Now you have the HbA1c, which is a single blood test that can give you a 3-monthly average blood sugar. You take a patient's blood at any point of time, doesn't even require fasting, and that single blood test of HbA1c, or glycosylated hemoglobin, I'm sure all doctors know about this test, will give you a 3-monthly average of that patient's blood sugar. For example, if that HbA1c value is more than 6.5%, we say that the person has diabetes. And in a diabetic, we want to keep the HbA1c below 7%. Then we thought about continuous glucose monitoring devices, and they were thought to be expensive, but I think in the last few years we have several types of continuous glucose monitors. For example, you can sense the blood sugar several times in a day. Some of these glucose monitors can measure blood sugar 288 times a day. Some of them can check it 100 times a day. Some of them can check it every 5 minutes. And the newer continuous glucose monitors are also real time. You can see the changes happening in real time. I think the use of these devices has done 2 things. It has helped doctors to understand diabetes better. And secondly, it has opened the patient's eyes to their own diabetes, because when the patient sees that, if I eat a laddu or a jalebi, my sugar goes up to this extent, they are willing to change their lifestyle so that they can control their sugar level. So I think technology to measure glucose levels has been phenomenal and is going to make a major impact in the times to come. And I think the use of smartphones and devices linking to that is going to make it even more easier. Of course, you have insulin pumps and newer gadgets, but I think many of these devices are still not in the reach of the common man because they are quite expensive and they have to be used in a niche group of patients. So I think what I see coming up in the next few years is probably new ways to measure glucose. On one side, you'll have the inexpensive ways to measure glucose, and on the other hand, you'll have the high-end gadgets which will also measure glucose continuously. This is, to my mind, the major change in glucose hyperglycemia management, hyperglycemia as well as hypoglycemia management, because hypoglycemia or low sugar is also a complication of diabetes cerebrus. This is what I think might change in the years to come.
Okay, so when we informed that we will be conducting an KOL interview with Dr. Unnikrishnan, most of the doctors were very enthusiastic and excited, and they have sent us a few questions. So I would definitely like to discuss them on their behalf. So, what is the occurrence of thyroid in India, and when we compare it to the international statistics, is it giving a burden on the Indian disease?
Well, I think if you look at data by Dr. Kochupillai, who has published the paper, Dr. Kochupillai was one of India's most eminent thyroidologists, and he suggested that India has almost a 42 million patient burden of thyroid disease. In our studies, we also found that India has a significant burden of thyroid disease. For example, 1 out of every 10 patients has thyroid disease. And therefore, I think compared to Western countries, these numbers are largely the same, because even in Western countries, thyroid diseases are common. For example, in the Wickham study, which was done in the UK, you had a significant proportion of thyroid disease, overt hypothyroidism as well as subclinical hypothyroidism. I think these are comparable, but I think what you had pointed out earlier is a lack of awareness on the patient side, because in these studies, when you sample a population, you will get all of them will have to give their blood test, but how many of them would actually go to a doctor and give a blood test? So therefore, there is a huge unrecognized burden of thyroid disease. To some extent, that is not there for diabetes, because diabetes has already percolated into newspapers and media. People all know about it. But thyroid disease, probably there is an opportunity to actually make people aware of thyroid disease. Yes, I see an opportunity there for better awareness.
So we have been listening to many of the programs at the institutes regarding reversal of diabetes. Is it practically possible?
Well, I think if you look at cure of diabetes, by cure of diabetes means that the HbA1c comes to a non-diabetic range. Now, to say that an HbA1c is normal and not diabetic or not pre-diabetic, you have to keep that HbA1c somewhere below 5.7 without medicines. So that is technically a complete cure or reversal of diabetes. I think that is very difficult to achieve. But if you look at a simple control of blood sugars without medicines, that is, if you want to keep an HbA1c of below 6.5% without being on medicines, I think reversal of diabetes is possible, and it is possible in two ways. One is in obese patients, those with a body mass index of more than 35 kilograms per meter square and they have diabetes, bariatric surgery, sleeve gastrectomy or gastric bypass or the new mini gastric bypass. These are all surgeries which reduce obesity, and once obesity goes away, diabetes gets better. But they don't just act by reversing obesity, they also act by acting on the stomach and the intestines and the gut related hormones change, and that change will reflect in an earlier reversal of diabetes even before the obesity gets better. So that's on one side. On the other side, what is very interesting is the use of very low calorie diets for diabetes reversal. I'm sure you must have heard of several fad diets that come across for obesity reversal. And whenever people use those diets for reversing obesity, diabetes also comes away. Now that is possible probably in the early stages. There was a publication in the famous journal called Diabetologia called the Counterpoint Study, in which they gave a very low calorie diet with a meal replacement to people with type 2 diabetes, and they demonstrated that diabetes could get cured by just an extreme form of dieting. Now, that kind of dieting should be conducted only in very specialized institutes under the care of specialized diabetologists and endocrinologists. And also, these kind of diets need extremely motivated patients. And what they demonstrated in the counterpoint study published in the Diabetology journal was that patients with diabetes of not very long, shorter duration of diabetes, who have just become diabetic or on a few medicines, they can potentially be reversed. But you cannot, somebody on diabetes with 20 years is on 100 units of insulin. That kind of patient is not the right patient for attempting a low calorie diet reversal. So obese patients who are actually having diabetes for short term, they are candidates. But again, these kind of diets have their own side effects. They cause electrolyte imbalance. They can increase ketone body. So starvation is bad for the body. So these are very specialized diets to be used by specialists. I think that these diets are not to be used in general. And for the general patient, a reasonable diabetic diet, good exercise, the use of standard medicines like metformin and then insulin, I think these are good for the average patient with diabetes.
Sir, as you were talking about metformin, I just recollected a question in my mind. Most of the oral hypoglycemic agents, they are not in pocket reachable for most of the patients in India. So are there any substitutes for metformin or gliptins so that it is into the pockets of patients?
I think metformin is probably the most economical, the most popular, the most effective, and probably the most safe treatment of diabetes. I think it's quite an economical drug also, and metformin has benefits beyond diabetes control. It has effects, it's weight friendly. There are some studies, in fact, suggesting that it may have a preventive effect on malignancy as well, metformin. So we published a paper on, not on human beings, but on pancreatic cancer cell lines in the lab, in vitro study, where we found that metformin nanoparticles might, even cause death of pancreatic cancer cell lines. Again, this was not done, this was a laboratory study done by basic scientists, and I happened to be just one of the authors of the paper contributing to the science behind it. But therefore the point is, metformin is one of the best medicines for diabetes, and it is a drug for initial choice of diabetes. And the answer to your question, has any drug been able to offer a cost-effective alternative to metformin? The answer is no.
Okay.
But yes, but if you look at a gliptin or a sulfonylurea, I think these drugs, there is really no evidence to choose one over the other. We do say that gliptins are excellent drugs because they don't produce hypoglycemia, but sulfonylureas are cost-effective, economical drugs which have been with us for decades now.
Yes.
So we have extensive experience of using these drugs. And by simply counseling the patients about hypoglycemia, I think they are also good drugs which we need to use, because in a country like India, where you have to think about not just the wealthy but also the poorest of the poor,
Yes, exactly.
I think sulfonylureas also have their place, and we should use these drugs.
Sir, corticosteroids have been abused by most of the general practitioners as well as specialists across in India. But what are your opinions regarding these abuse? Are they should they be used or should not?
I think corticosteroids are just a tool, and we shouldn't blame the tool. The tool is only a tool. It is how we use the tool that matters. So they are double-edged drugs which have got a lot of good effects and a lot of side effects when used. So the pharmacological benefits of, say, corticosteroid inhalation in bronchial asthma, for example, means that they are wonderful drugs to use. Of course, they have some side effects. I think the use of oral corticosteroids, which are very strong in high doses, unnecessarily for mild diseases, is probably to be discouraged. But to use steroids for relevant major diseases, I think it's a good thing to use it for, say, a very systemic autoimmune disease which is not responding to standard therapy. So I think, as like any drug, it has its use and its abuse. It's a fine balance. It's important that corticosteroids are not stopped suddenly, because stopping it suddenly can trigger an adrenal crisis. So that is something important to keep in mind. In general, I think in India the practice is changing, and doctors are more aware of the use of steroids and the proper rational use of steroid. And I think that earlier, when I was doing my training in CMC Vellore, I have seen steroids being used excessively in high doses for skin diseases and other things. But I must say, in the last 5 or 6 years, this seems to have declined, and there is a good awareness among the medical profession. And I think that's a very welcome sign. So it is a tool. Let us use it judiciously, carefully, for the benefit of the patient. Let us not stop it abruptly. and let us stop it gradually and let us make sure the patient is looked after safely.
Sir, in an hypothyroid individual having TSH level normal or comparatively low, so most of the endocrinologists, they shy away from using combinational therapies. What are your opinions? Would you prefer a combination therapy, or you would go a trial before?
I think the question is here is that if the TSH is slightly high, would you give just a T4 therapy or would you give a combination of T4 and T3? Now this rationale for a combination came through because treating thyroid hypothyroidism is not easy. You can give thyroxine, but the tablet of thyroxine cannot produce thyroxine in exactly the way that the thyroid gland produces it. So there will be a gap between what the tablet does and what your body can do. Because of that mismatch, sometimes the patient may have a lot of symptoms which the tablet cannot address. For example, depression and neuropsychiatric symptoms and tiredness, and therefore for this reason, people tried a combination of T4 and T3.
Okay.
And they found in a few selected studies that in a few selected individuals it showed benefit. Personally, in my career, I think I have been practicing endocrinology since 1998, and I have never needed to use a combination of T4 and T3 for treatment of hypothyroidism. In a very selected group of patients, if somebody very judiciously knows and uses it, of course T3 is a very expensive drug, not available in India actually. I wouldn't blame that use, but actually I haven't found the need to use it so far. I think it's more important to counsel the patient because the combination of T4 and T3 hasn't given the kind of benefit it should. So I would say stick to T4 therapy, levothyroxine therapy for the moment, and not consider T3 as an add-on. Of course, if you look at the new American Thyroid Association guidelines, they have given the option that in some selected occasions you can use it. That option has been given, but that should be the exception rather than the rule. The rule should be standard T4 or levothyroxine therapy.
Yes, sir, we were talking about TSH and thyroxine.